Thank you. Oh, I never get applause before I present. That's so nice. So again, my name is Tammy Pozerycki. I have been in the world of healthcare and working with folks with dementia for 20 years. My grandmother had Alzheimer's, and so living the journey personally, along with working with so many families, I have developed a true calling and passion in my life to improve the quality of life for those living with dementia. And educating people and removing the stigma and increasing awareness has really spread because of our dementia-friendly community efforts. All those initials after my name are just, I train, and so I have all kinds of certifications along with training. But my day job is actually 9 years ago, I opened Pleasantries Adult Day Program in Marlborough. It's in a home, and we cater to folks who are living with the disease or other dementia, who are living in the community. They come to my home for the day, and we just create a wonderful opportunity for them to experience a fun and purposeful and meaningful day. So that's my baby, but I work as a consultant and educator as well. So my goal for you today, I do want to mention the Chana 7 up there is actually the funder, has provided us the grant money to be able to train folks in all 3 communities. So they've been completely supportive of that, which has really helped us to spread the education. My training objectives for you today. I want you to learn about Alzheimer's and other dementia and learn that it is so important to understand what the symptoms are, what the signs are. Is it a disease process, or is it a symptom of something else that could possibly be treated? I want you to understand that when someone with dementia communicates, maybe in what we call behavior, I like to call it unwanted communication. Because when we understand the feelings of the person with dementia and their desire to communicate their needs and wants that are unmet, it can come across as what some people call behavior. And it's unwanted by us because it makes us feel uncomfortable. So what are some of the barriers to that good communication? I'm going to teach you some strategies and interventions. And first, I'd just like to ask you folks, has anybody been in their personal life affected by this disease? More than half the room. So that just goes to show you the epidemic proportions of this disease process. I want you to learn how to jump into the reality of the person who is living with this disease. It is not about us. It is not about our reality. It is about the thoughts and feelings of the person with the disease. So some facts to just express how important this is. It is the 6th leading cause of death in the United States. 1 in 3 seniors actually dies with a dementia disease process. There are 78 million baby boomers coming of age now, and age is the biggest risk factor in developing a dementia disease process. It affects all cultures. No country in the world does not deal with this disease. Everybody does. It doesn't matter the race, the culture, male, female. And one of the things to consider is that it is now affecting folks in their 40s, 50s, 60s. This is not just an old person's disease. So what is normal aging versus dementia symptoms? All right, show of hands, how many of you folks have lost your keys or lost your cell phone? Pretty much everybody. How do you find what you've lost? You retrace your steps. Someone who has dementia is challenged with that. There's something in our brain that happens, it's called cognitive mapping. So in normal aging, we may experience the need for less distraction when we're learning new material, or we may take longer to learn new information. Some of our senses may diminish, our hearing, our vision. We may have slower reaction time, but our cognitive mapping stays intact. Someone with dementia, that cognitive mapping declines. Cognitive mapping is the way we wayfind. So how do we drive and find our way from point A to point B? How do we park our car in the Walmart parking lot and come out to the parking lot and go, oh my gosh, where did I park my car? We cognitively map that. We never know when someone has dementia when that cognitive mapping is going to fail us. And that is the risk for those living in the community with dementia, where they're wandering, may get lost, or they're driving and may get lost, or they may enter the town hall and get lost. I want you to understand that dementia is simply a set of symptoms. Memory loss, short-term memory usually goes first, long-term memory second. Confusion to place and time, poor judgment, we see poor hygiene. If you think of the brain as our control center, it takes care of everything we do. It tells us how to eat, how to talk, how to breathe, how to move. And with dementia, the plaques that are building in our brain are starting to kill off our brain cells, so that the brain starts to forget how to tell our body what it needs to do. Saying that dementia is symptoms, it is not a diagnosis. So if a physician says your loved one has dementia, that's not a diagnosis. You need to get a workup. Why is it so important for someone who are displaying these symptoms to get a workup? Is because it can be a reversible cause. Okay, I want you to understand there are things that will cause someone to have memory issues, confusion, but it's not a dementia disease process. So untreated depression. I had a gentleman, Nick, who entered my program. His daughter brought him to me saying that he had Alzheimer's. He was a caregiver for his wife for 4 years who had Alzheimer's. She passed on, and he went into this deep, dark clinical depression. He was withdrawn, he was isolative, and his daughter just assumed that he had Alzheimer's. So he started coming to my program, and I asked her to please get him worked up for depression. He started a pharmacological treatment, plus coming and socializing in the program, and within a month, all the symptoms of dementia disappeared. His memory was intact. He had no dementia. Oftentimes I train audiologists, and the daughters or sons will bring their loved one into the audiologist and say, oh, my mom has dementia. Well, once they check the hearing and fix the hearing, all of a sudden, the dementia goes away, because now she's participating in conversation, she's not withdrawn, and she hears what's going on. So oftentimes it's just misunderstood. But there can be vitamin deficiencies, nutritional deficits, infections going on, brain tumor, mental illness undiagnosed. Lots of causes for dementia symptoms. These are the non-reversible, fatal dementia diseases that are not curable. Alzheimer's is the most prevalent, so we talk about it a lot. The Alzheimer's Association, they deal with all these dementias. And it's important to understand them because they are different. And they affect people differently. And we see symptoms different. When you've met one person with Alzheimer's, you've only met one because they are so different. Lewy body dementia and Parkinson's, they're very similar. They're a brain dementia disease process, but that affect the neuromuscular. So someone with Parkinson's will look like they have tremors, they are shaking, they have difficulty ambulating, they may fall a lot. Those presentations start first. So we see the physical stuff happening before we see the cognitive impairment. Along the journey of Parkinson's, we will see a dementia disease process, eventually affecting the brain. With Lewy body dementia, oftentimes misdiagnosed as Alzheimer's or Parkinson's, very different. With Lewy body dementia, we see the cognitive impairment first, and then we see the neuromuscular problems come second that look like Parkinson's. Why are they related? Because they come from the same protein in the brain developing the plaques. They're just two different diseases. Anybody know the famous actor that committed suicide who was diagnosed upon autopsy with Lewy body? Robin Williams. He was first diagnosed with bipolar disorder, and then they thought he had Alzheimer's, then they thought he had Parkinson's, and then they did the autopsy and he actually had Lewy body. The thing about Lewy body and Parkinson's, and if you've seen it on TV, most recently they've been talking about Parkinson's and those affected having hallucinations and delusions. So that's pretty prevalent with those two diseases. So Lewy body and dementia, Lewy body and Parkinson's can be very difficult in the process. With Lewy body, folks can get aggressive, can get very angry, and so oftentimes will be institutionalized earlier because it's more difficult to care for the caregiver to care for their loved one. Frontotemporal lobe dementia, or what they've called Pick's disease. They kind of all lump it in what we call FTD, because that's deterioration is happening here, frontotemporal lobe. This is the part which controls our social graces, our ability to be socially appropriate. These folks are very challenging because they can be inappropriate. They have no ability to know what personal space is. They lack empathy. And most notably with frontotemporal lobe is that they will lose their ability to speak using words first, which can be very frustrating because they know what they want to say and they can't say it. And those with frontotemporal lobe, we can see the onset of that late 40s, 50s. I've had a woman in my program with frontotemporal lobe, and I could write a book on our journey. It's a very impulsive dementia disease. Folks also have an obsessive compulsive component. She was very, very obsessed. Now her senses were diminishing, taste, smell. So she was trying to compensate with that with very heavy colognes. She chose, and for those gentlemen who choose Dracar Noir, forgive me, but Dracar Noir. Has anybody smelt that? Oh my gosh. It is potent. But she was trying to get the scent and it made her feel good. Because it was stinking up the transportation van and it was stinking up the entire home of Pleasantries, we had to remove that. Problem is, they don't lose their ability to problem solve. So she took it upon herself when they were visiting the son's home to search his house. And what she found was a can of Lysol. And that is what she sprayed on her body, because she was needing that. Now at Pleasantries, she requires a bottle of lemon juice. Lemon juice, you know the squeezed lemon? Everything she eats gets doused with lemon. To you or I, that is really gross. But it's the only way she can taste the food. Those are the senses in the tongue that are still there. So, frontotemporal lobe. Marlboro Police Department was called when she crossed Route 20 and went into Walgreens and started stealing stuff. Gone are the days of her getting thrown into the back of a police officer's car in handcuffs, because they've been trained. It's no longer you're a criminal. You're a lovely lady who has an incredible history as a special education teacher who has an awful disease process. Vascular. Does anybody know what vascular dementia is? What's that caused by? Strokes, heart disease, anything restricting the blood flow to the brain. It progresses much different than Alzheimer's, because when you have an event, you could have a stroke and then have residual cognitive impairment and then plateau for a while. I have folks with vascular that remember things that I don't remember. But Alzheimer's is a steady decline, and vascular can plateau. Mixed dementia is just thrown in there when doctors don't know which one it is, and they just call it mixed because they can't figure it out. Now, diagnosing, they've come a long way. With PET scans, MRIs, CAT scans, they're getting better. They're probably around the 90th percentile now of making a diagnosis, but you can't get the proper diagnosis until autopsy. 100%, let's say. Huntington's disease, genetic disorder, affects 50% of the family, usually onset late 20s into your 30s. It affects the entire body. Anybody here deal with Huntington's or have seen Huntington's? Yeah, it's a wicked, wicked disease, but it is a dementia disease, so it eventually affects the brain. There are long-term care institutions that actually have specialized Huntington's units, which have cradle beds, and that's because they have no ability to control their movement, and they flail. So their arms, their legs, their upper body just flail uncontrollably, and they go from diagnosis to total care in a very short span of time. Creutzfeldt-Jakob disease. Took me a long time to pronounce that. Anybody know what that is? Anybody hear of mad cow? Mad cow. So in Europe, they had the outbreak of the tainted cow meat that humans ingested. It goes through the bloodstream straight to the brain and causes dementia. It's very, very rare. We don't really see it that much anymore. However, with CJD, shortened for Creutzfeldt-Jakob, we have a genetic CJD. In fact, a good friend of mine who owns a home care company, her mother died at 62 with CJD, and it is genetic. And she has 2 children. So she's very nervous about how that's running in her family. Korsakoff syndrome. Does anybody know what that is? It's really, we call it a syndrome because it is different from the other dementia disease processes. A lot of folks in the community living with Korsakoff's. Korsakoff's is caused by alcoholism, okay? Ingestion of alcohol provides what's called Wernicke's encephalopathy, which is a lack of B1 or thymine. So that affects the brain. So the person excessively drinking causes the dementia syndrome. So that's why it's different. Chronic traumatic encephalopathy, CTE, the one that's in the news right now. Anybody know what causes that?
Concussion.
Concussions. Repetitive head injury, concussions. Our sports players. Who is the famous Patriots player who committed suicide? Hernandez, there was one before him. Junior Seau and Hernandez. Anybody hear that autopsy result? Pretty darn scary. His brain had the worst case of CTE in a living human they've ever seen before. I mean, I think he was a little sociopathic on top of it. But, and last week, I sort of made my own theory about our pal Gronk. What did Gronk do?
He was impulsive.
He was so characteristic of what we call CTE, of what he did, his behavior. So it is scary. My son, he's 24 now, but through his career of football, 4 major concussions. Very scary, because concussions can lead to not only CTE, Alzheimer's and ALS. So concussions are bad, very bad. But CTE, the issue I see with it is that it is going to become an epidemic. And the folks are getting it and they're in their early 40s. And the issue with CTE, they can become very violent, suicidal and homicidal. And there's a lot of domestic violence issues going on with CTE as well. And what are we going to do to care for these folks? Certainly, you know, I mean, the theory is they go into a nursing home, long-term care when they need it, but they can be violent, you know? So I don't know where the care for these folks is going to go, but it's a concern. And then we get to Alzheimer's. Alzheimer's, the most prevalent of all the diseases. Does anybody have any questions on that last slide with all the different diseases? Yes.
So with respect to, I know it's non-reversible, but there are medications that can help, right? I mean, psychiatric or other medications in some cases?
So with pharmacological intervention, yeah, it's a hype. You know, you've got Aricept, Namenda, Namzaric, Exelon. These are all medications that are meant to slow it down, improve the memory. What happens most often is that the individual ends up with so much gastrointestinal upset and side effects that they come off the med. It does them no good. When you have someone that has some unwanted communication, hallucinations, delusions, behavior, oftentimes physicians will put them on an antipsychotic. Contraindicated for older adults, especially with dementia. So we are needing our physicians to be much better educated on how to treat this disease. Because right now, there are drug trials going on. Alzheimer's Association actually has a program called Trial Match. We're looking for actually people with no symptoms. Preclinical. That's what preclinical means. Preclinical is the stage when no one knows those plaques are building. Nobody knows they're getting it. There's no symptoms, but the brain, it's happening. Once we get into mild cognitive impairment, that is actually a diagnosis now that doctors are using because there are definitely symptoms. But folks with MCI are still driving, still working, still actually participating in their daily functioning in life. But they are starting to notice changes. They're starting to have issues with their memory. Family might pick up on it, but oftentimes with cognitive testing, you can't tell if the person has MCI. We have something called an intellectual reserve. If you are super intelligent, there's oftentimes the chances that you're going to be super covering up for a long time. And oftentimes, spouses are really good at this. Spouses cover for each other. So not oftentimes people won't pick up on the symptoms. So once it moves into early, now everybody notices. Oh, go ahead.
Tammy, what are some of the symptoms that you start to see when it comes to the mild cognitive impairment?
Memory issues, short-term memory deficit, Once in a while, confusion. There's a gentleman, I went to do a consulting job down in Marshfield yesterday, and they run a social model day program out of their assisted living. And one of the executive director's issues is that the director of the program is looking like he has MCI. And he was providing me a tour of the facility yesterday, and he said, "Have you ever seen the theater?" And I said, "No, I've never been here. I'd love to see it." And it was 2 doors like this. The one where it says health room there, it said restroom. That door was open and into the movie theater. And I was standing closer to that door, and he was trying to enter the restroom, and it was locked. And he said, "Oh, I'm sorry, I don't have the key." But inside here, it's a movie theater, and there's seats, and I'm standing right in the corridor looking into the movie theater. So it's like that, symptoms like that show up that you go, oh yeah, something's off. The other thing you'll see are mood changes, personality changes, mood swings, getting angry, getting depressed. Those are the things we start to see in MCI. But when someone moves into an earlier stage of a disease process, everybody starts noticing. This is when they lose their job. They can't hold a job. This is when they shouldn't be driving anymore. And this is really when the families need our support, because everybody goes into the phase of the big D. What's the big D? Denial. The person with the disease, the family, they shut the door. They don't want to, they put their blinders on. They don't want to know that it's happening. But there is so much support now. Through the Alzheimer's Association, through our efforts of Dementia Friendly and holding all these memory cafes, and there's so much out there for families. So hopefully with you being educated, you can then go out and share that with other folks. Once somebody gets in the middle stages of Alzheimer's, this is when they are completely dependent on their caregiver. This is when caregiver burnout happens. This is when the caregiver needs respite, needs a break. Because that person with dementia doesn't know what the next minute of their day looks like. They don't know what the next steps are. They're relying on that person to guide them through the next steps. Once it gets to late stage, usually it's 24-hour care. There's continence issues. Someone with dementia develops bladder incontinence, then bowel incontinence. And at that time, that's usually when the family looks to long-term care, institutionalization, because now it's gone beyond the point of them being able to do the care. Any questions on the stages before I move on? Okay. Yes.
How long does each stage last?
Very good question. It is different with everybody. The span of the disease process could be 17, 18 years. Before someone's diagnosed, the plaque start could be 10 years prior. So this is a journey, a long journey for the person with dementia and the family. This is a picture of what the brain looks like in advanced Alzheimer's. The brain is dying off. It loses almost 2/3 its weight by the end. It's shutting down. And eventually, in late stages, the person can't chew, the person can't swallow, can't eat, can't speak, and can't breathe at the end. One part of the memory, though, that is fascinating, that never leaves the brain, is music memory. We use music as a form of therapy because it reaches them in the late stage. You can search online for a video of a woman, late stage Alzheimer's, in bed, not ambulatory, not speaking, put in music that sparks that memory, and she can sing it. It's amazing. I have a gentleman who used to bring his wife to my program, and she now is in assisted living, memory care, and does not speak. We call that aphasia, when someone loses their ability to speak. She comes to my memory cafe though, and it's wonderful to see her and her husband. And her husband told me that he takes her to Mass every single day. Not because they're very religious, because that is the only time he hears her sing and hears her voice. So they go to Mass every day. I thought that was wonderful. So this is, now that we've talked about all the negative crap with this disease, this is the beauty of the disease. The part of the brain we call the amygdala, very small part of the brain, they can still feel like you and I can feel. They can still express their emotion, and they become super sensitive to how you're feeling. So whatever you're feeling, they will pick up on and mirror back to you. So if you're having a bad day, they're going to have a bad day. So at Pleasantries, the policy is, look, everybody's got stress, everybody's got life stressors, and if you're having a bad day, it stays right outside that front door. And you come in and smile and fake it till you make it. Because that's how important it is with our approach to folks with dementia. So in learning about dementia, you need to learn a few key concepts. First one, smile. We all smile in the same language. It is your way of unlocking the door to communicate with someone with dementia. Smile. It conveys warmth, acceptance. The next word is approach. We use that word because it sets the stage for either good communication or not so good communication. We want to think about our approach, and we're going to talk about how to approach. Touch, I always throw that in. They love touch. Handhold, hug, pat on the back. You got to know the person though, because you got to know that that person wants to be touched. Because otherwise you might get that little sense of unwanted communication back at you if they don't want to be touched. Reassure. We use that word to take that person out of their stress and anxiety, to reassure them that they are safe. Okay? Redirect is a word we use when we want to focus their attention on something not so negative. When we see someone doing something who has dementia, either it's unsafe, harmful to someone or themselves, or it's just bothersome, we want to change it. We're going to learn a process to change it. Because someone with dementia, you can't just go up to them and tell them, stop doing that. No, get away from that. You shouldn't be doing that. All that is just going to perseverate it. So we're going to learn a 3-step process on how to redirect. The next word, fiblet. Fiblet was the best word ever invented in the world of dementia care. We do not use the word lie. We don't say white lie, because lying is so negative to families. Nobody wants to lie to their loved one. Reframe it as a therapeutic non-truth. Okay? What that does is that you jump into their reality and you reassure them and you can redirect them. So I'm going to give you an example of a fiblet. Arthur in my program around 3:30, 4 o'clock in the afternoon starts looking out the door in the window saying, "When's my mother coming to get me? When's my mother coming?" Arthur's 85 years old. So our reality, Arthur, your mother died 30 years ago. What are you talking about? She's not coming to get you. What did I just do to him? Stressed him out and devastated him. because that is the first time he is hearing that his mother died. First time. So now I've sent him to a spiral of grief. Fiblet. Oh, Arthur, she's at the beauty parlor getting her hair done. Once she's done, she's gonna be by to pick you up. I understand that you want your mother and you want to go home, because I do too. But while we're waiting, would you mind coming with me to help me fold these towels that need to be done? What I did there was a 3-step process, and I used a fiblet. When we are speaking to someone with dementia, we want them to know we've listened. That's called validation. They want to be heard. He wanted someone to listen to him when he was asking for his mother and when she was coming. When you fiblet, it has to be believable though. Because if I had said to Arthur, oh, Arthur, your mother's at work. When she gets out of work, she'll be here. What if Arthur's mother never worked a day in her life outside the home? Then he would have called me out on it, and then all mistrust. The other thing is sometimes the fiblet, you need to know where they're at in their disease process. Too early, they're going to call you out on it. So fibleting has to be, the only time we use fiblet is to join them in their reality to help us redirect, okay? And to help them calm down. A trigger. A trigger is what causes the unwanted communication. It can be internal, it can be external. Internal would be something like pain, pain that they can't express. External would be a very overstimulating, loud, crowded environment. But that's what a trigger is. Delusions and hallucinations, I touch upon that because to understand dementia, you need to understand they're living in a delusional world. We're not talking delusions and hallucinations like if someone was strung out on drugs or if they had schizophrenia. Delusions and hallucinations with dementia are completely different, okay? But what can come out of them is very negative stuff. They can become accusatory, paranoid, violent. Delusions and hallucinations in the dementia world, a great example is when someone with dementia looks into a mirror. A mirror can be a very bad thing with someone with Alzheimer's. Why? Because when they look in the mirror, they don't see themselves. They are not old anymore. They reverse in age. I have a 98-year-old commander of a Navy of a ship come into my program in his suit, coat, and tie, and you better call him commander. Because that's where he's at in his disease process. He's back in the day when he was commander of a ship. Now, when you look in the mirror, when they look in the mirror, you have a lovely older woman looking in the mirror, having a conversation. She thinks she sees her mother in the mirror. No distress. She's engaged. And she's happy. No need to interfere with that. That's a delusion, a hallucination that we just leave alone. Now, if it was a gentleman looking in the mirror screaming, "Get out of my house!" and he was fearful, that's a hallucination and delusion we want to treat. We want to help them with. So hallucinations, they are seeing things, hearing things, tasting things, touching things that aren't real. Delusions are just a misinterpretation of the truth, their own belief of what reality is. And with dementia, oftentimes they live in a delusional state. That means we have to jump into that delusional state, okay? Sundowning, that's a phenomenon that relates to the sun going down, decreased light. What happens, it's late afternoon, the person's getting much more confused, agitated, distressed. We don't really know what exactly causes it other than The person, if they sleep good at night and they've been engaged in activity all day, they might be fatigued, they might be tired, but the only treatment for sundowning is to actually raise the lights, make it look like daylight inside, and get someone engaged in a purposeful, engaging activity. Also, music therapy works wonders during sundowning. But this is when caregivers struggle the most, this part of the day, because they shadow their caregiver. That caregiver can't even go to the bathroom without the person knocking on the door because they're scared. And they need the dependability of that caregiver to be right by their side. Wandering is an issue for all of us in the community. It happens, well, statistically they say 6 out of 10 will wander. In my span of my career, I feel like it's more 8 or 9 out of 10 will wander. The thing to remember about wandering is that they don't just decide, I'm going to leave my house. There's always a goal. There's always a goal because whatever reality they're in is telling them they have to do something. It's that I have to go to work, or I have to go to the bus stop and pick up the kids. That is truly why they go. But the problem is, once they go, the cognitive mapping stops, and then they don't know. So when they're found, they're asked, where were you going? And they go, I don't know. It's critical if the person is not found within 24 hours. They are at high risk of injury or death. There's a phenomenon that happens with Alzheimer's and also autism for folks who wander, is that they will be drawn to water. We don't know why. It's a phenomenon. That's why search teams go out and they look ponds, streams, lakes. There was just one that happened in Sudbury. When I did the Marlborough Police Department training, they told me of a story, because Marlborough has the search dogs. Sudbury doesn't. And by the time they called Marlborough, got the search dogs, got them out to Sudbury, she was found in the pond. She had drowned. But I don't know about you, but I have a Facebook feed that I am constantly getting people, the silver alert, constantly getting people who wander off. Most cases, people will be found within 1 to 2 miles of where they leave if they're on foot. If they have access to public transportation, people are good at problem solving. They will not lose that skill. There was a woman in Massachusetts that literally packed a bag, bought a ticket to Florida, got transportation to the airport, went to Florida, got off the airplane and had no idea. And she was reported missing in Massachusetts. So the cognitive mapping piece is so important to understand. There was a gentleman in Massachusetts who him and his wife had a home in Maine. And he got in his car one day in the middle of winter and decided to drive to that home in Maine. Cognitive mapping was perfect to get him there. Got him to the home in Maine. He got out of his car, went onto the porch that was snow covered, and said, I don't have any keys to get into the house. That's when the cognitive mapping stopped. He did not have the wherewithal to get back in his car and drive home. And he died on that porch in the snow. So when daughters or sons tell me, oh, well, my mom's still driving, but she just goes from the house to the store to the bank, denial that it's not going to happen. Especially if you live in the city of Marlborough, where there are detours everywhere. They can't wayfind through detours. So what are we looking for with folks that wander? They may not be appropriately dressed for the weather. We're not just looking for an older person in their 80s and 90s with cognitive impairment anymore wandering. The police just got called to a gas station in Marlborough where the gentleman working there called because the guy got out of his car in his 50s and said, I don't know where I am. So this is really something we have to build awareness of in our communities. These are the dominant feelings of someone with dementia. This is what they live with all day long. Negative, negative, negative. It's about the caregivers and programs and supports that can provide an opportunity for them to feel good about themselves. I'm kind of moving us along. I don't want to keep you too long. The communication changes that happen with someone, word finding difficulty, but they have these moments of lucidity where you go, where the heck did the disease just go? The moments of lucidity are when I tell folks, enjoy that moment. You can create new memories. You can create new memories with a loved one with dementia through the amygdala, through reaching their emotions. An example of that, I had Ralph coming to my program, and Ralph was losing his social skills. He was losing a lot of his ability to use his words. And one Friday afternoon, he helped me clean out the vegetable gardens. It was in the fall. And he has no memory whatsoever. That was on a Friday. On Monday morning, he came in, sat at the breakfast table, looked out the window and pointed and said, "Did we finish that job out there?" That blew my mind, that he remembered that from Friday. And it was because, why? Why do you think that Ralph remembered that?
It's an emotional attachment.
Absolutely. He felt useful. He felt needed. He knows he was helpful. And that's the way we improve the quality of the life of these individuals. They don't have a job to go to. You and I all had a reason to get up, shower, get dressed, and go somewhere. Someone with Alzheimer's, why? There's no reason. We have to help them with that reason to get up. That three-step process I talked to you about, the validation, the empathy, the redirect. When I teach healthcare professionals, this validating them, empathizing with them, and then redirecting them works all the time. But you can't possibly redirect without validating them, empathizing with them. Some people think, oh, I'll just change the subject. And once you do that, they feel dismissed. They're not being listened to. I tell folks, we have 2 of these and 1 of these for a reason. We have to become good listeners and understand. So some of the strategies. Smile, number 1. Always make eye contact and at their level. So if you're way up here, you gotta get down at their eye level. They will lose their senses during dementia disease process. Vision, hearing, taste, all that diminishes. So if you approach someone from the back of the side, you may startle them. Introduce yourself. Ask what they like to be called. Mr., Mrs., Doctor, Commander, right? When you ask someone with dementia a question, make it simple, and you have to be patient. It can take up to 90 seconds for that one question to be processed in their brain. What do we do in our everyday life if we ask a question and nobody answers?
Ask it again louder.
Yeah, ask it again louder, or ask it a different way, or ask a different question. But every time we interrupt that, we've lost the communication if we don't give them time. Those who are nonverbal may not be able to answer. But if we give the person the ability to process, they might be able to answer. We speak very quickly in our own native language, and I teach folks to really slow that down, pronunciate the words, and take your time. Remove distraction. They need a very calm and quiet environment because they can't decipher in a noisy environment what you're trying to say and what's going on in the background. So it's reducing that. What do we do with our voices when we're talking to an infant or a toddler? Oh, you're so cute.
Sing songs.
Yeah, and it's demeaning, really. It is to someone with dementia, an older adult. And there's a part of this disease, once it progresses to a certain point, they actually can't hear that high pitch. So we want to lower our tone of voice. And can I tell you, they love compliments. They are losing their self-esteem little by little. So they love compliments. And I'm not talking, didn't you do a good job on your plate? You ate everything. Wonderful. No, no, no. I love your dress. That's gorgeous. Did you just get your hair done? It's beautiful. They absorb that like a sponge, and it gives them a little boost for the day, right? And then using of fiblets, join them in their reality, offer the praise, connect and redirect, always decrease the level of danger. I always put this in my trainings, Maslow's hierarchy of need, because it explains what happens with someone so well. When we're born, we have physiological need. We need to be fed, food, clothing, shelter, right? Safety and security. We need that. We need to feel safe and secure. We need love and belonging. We need self-esteem. We all build that. And then at some point in our life, we reach self-actualization. Someone with a dementia process slides down the other side. So they lose a little bit of all that triangle every single day. It's up to us to be able to fill that back in for them. These are the benefits of good communication. You're instilling better self-esteem. You're validating them. You're listening to them. It also diffuses power struggles when we get into power struggles with folks with dementia. And it can reduce what happens, what we call a catastrophic reaction. A catastrophic reaction is something blown way out of proportion because we weren't listening, we weren't meeting the unmet need and want, so it got blown way out of proportion where the person can get very aggressive, get violent. And when someone has unwanted communication, guess who I always look to? The caregiver. The caregiver. What is the caregiver doing? These are the barriers, and I think I talked a little bit about these barriers to good communication. Never argue, never criticize, never challenge, never say no, never correct. It doesn't matter what time of day it is and what day of the week it is. You know, if they insist it's Sunday morning at 10 a.m. and they got to go to church and it's Thursday morning, I hear you want to go to church. I do too, but guess what? The church is being renovated and they closed today. But you know what? Maybe we could find it on TV and you and I can sit and watch Mass on TV. So much easier than it's not Sunday. The church isn't open. Don't you remember? I told you 3 times. It's instilling that negativity, okay? This is what happens when we don't enter their reality. When we try to challenge them, these things happen. And common challenges that you might see in your professional work, in your personal life, you know, all these things you might see. So my goals for you is to hopefully put some of these strategies and practices in your everyday life, personally and professionally, and take this information and spread it. Spread it to your family, spread it to coworkers. When you see someone engaging with someone with dementia and they're not doing it right, educate them. Because that's so important to that person's quality of life. And responding rather than reacting. And responding certainly takes forethought. And it takes thought, okay, how am I going to approach this situation? Rather than reacting, okay? And thank you very much. You're welcome. Thank you.